Chairman, the colleagues, I'm going to address the pharmacodynamics and the possible interaction with immunosuppressive therapy. With solid organ transplantation, there is always a T cell activation, and what we are trying to do as physicians working in the field of transplantation is to minimize or decrease or even stop it totally, because T cell activation definitely is going to lead to damage of the graft. Here is the kidney, and once the kidney is placed without immunosuppression, the antigen-presenting cells will start to identify these different antigens and start to interact with the T lymphocytes, which will proliferate here within the lymphoid organs. These cytotoxic CD8 T lymphocytes will start to attack the kidney, causing tubulitis or maybe arthritis, and this is acute rejection. And we want this process to stop in order to prevent damage occurring to the kidney. And looking closer at what is happening, we can find this busy slide showing you the various signaling and the major three signals, which is signal 1 and signal 2 and signal 3. And here's the co-stimulation, which is recently, we have some medications developed monoclonal antibodies to block this as well. And then we have here the nucleotide synthesis, which is responsible for proliferation. So these are the various sites that we know so far are related to the proliferation of the T cells once it realizes that this is a foreign antigen. And for each one of these signals and cluster of differentiation, or CDs, now we have specific immunosuppressive drugs that work at these various sites, and you can see the names here of these various immunosuppressive drugs that will block these sites, thus preventing the proliferation of the T cells and the attack and rejection that occurs on. One point about the various immunosuppression is problematic because they have such a narrow therapeutic margin. If you give too much, this could lead to toxicity, and if you give a little, it could lead to rejection. So this very narrow therapeutic margin needs to be focused upon, and we have to realize how important it is to keep all the drugs within this therapeutic margin. Now, this is not always easy, because testing the pharmacokinetics of drugs is very good. There is inter-patient differentiation, not to mention there is inter-patient differences, as well as intra-patient differences as well. There is always a thought and a search for new methodologies to address this particular point in order to get the optimum effects of our immunosuppressions. Now, this is just a list. I'm not going to address each and every one of these immunosuppressive drugs. It's a very big list, and this is the rest of it. As you can see, our immunosuppressive drugs now have evolved into many, many forms, and all in the end are working on, in the majority, are working on the prevention of proliferation of the T cells. So when I'm going to address pharmacodynamics, I'm going to take an example of the CNIs, which prevent the proliferation of the T cells, and this would cover most of these immunosuppressive medications. Now, pharmacodynamics is the study of the biochemical and physiological effects of drugs, whether on the body or a microorganism or a parasite within or on the body, and the mechanisms of drug actions and the relationship between drug concentrations and effect. So this is what is pharmacodynamics all about. For CNIs, the optimal monitoring strategy that we are using now is a controversial issue. We are using the pharmacokinetics and monitoring the C0 and the C2, maybe for sirolimus, cyclosporin, and blood levels for tacrolimus, and this is widely accepted. But the most reliable pharmacokinetic parameter for CME dosing is the assessment of the ECMI area under the concentration time over a period of 12 hours. This is definitely not practical. So monitoring by traditional pharmacokinetic data is hampered by the fact of missing perfect association between the drug exposure and the pharmacodynamics, which would interfere again with the pharmacokinetics of a particular drug, even if we are using what is supposed to be the best tool available now, which is using the C2 levels for cyclosporin. Now, pharmacodynamic monitoring of calcineurin inhibitor passes into two channels. Whether we are going to use the non-specific pharmacodynamic assays or the specific pharmacodynamic assays, which is related directly to the drug itself, as you can see from the list here. Over the coming few slides, I will try to explain these points. Now, we know that CMIs work on prevention of T-cell proliferation, and T-cell proliferation means there will be various markers, such as inflammatory cytokines and so forth, that will tell us that T-cells are proliferating. So if you find decrease in these levels, this means everything is fine and the CMIs are working well. But when there is inefficient immunosuppression related to the CMIs, you may find disturbances in these levels, meaning that we have T-cell proliferation. Just to remind you what the CMIs are doing, here you can find cyclosporin A and tacrolimus. Both have a different substrate to work upon. The cyclosporin unites to cyclophilin, while the tacrolimus binds to the FK binding protein. Eventually, both of these would inhibit the cyclophilin. Cyclophilin is very important because when we have an excess of cyclophilin, this pathway, which is the nuclear factor of activated T cells, is activated. Now it is not activated under the effect of inhibition of the cyclophilin. When this is activated, of course, we have genetic representation of the various cytokines in the messenger, as messenger RNA that will later on develop the various cytokines that are responsible about the occurrence of rejection or bind to specific sites on the cell surface, leading to its proliferation. Non-specific pharmacodynamic biomarkers are general and reflect the overall activity of the immune system. One advantage of these non-drug specific pharmacodynamic monitoring methods, just like the one I described, is that the effects of combined drug therapies can be evaluated. Meaning, if you are giving a patient a steroid and mycophenolate and calcineurin, all of these are working to prevent the proliferation of the T cells. So generally speaking, if you have no proliferation of the T cells, means your patient is adequately immunosuppressed, but you cannot really say at this stage that it is due to deficiency or inappropriate actions of a particular immunosuppression. So most of the currently used immunosuppressive drugs are inhibiting the lymphocyte proliferation, so that's why this is a valuable tool in this context in particular. Now, there are other methods such as the assessment of the immunosuppressive drug interactions, and in this particular research, cyclosporin, tacrolimus, MMF, and sirolimus were tested by flow cytometry, detecting the lymphocyte proliferation signs, and these are the proliferating cell nuclear antigen, the BCMA, and the cluster of differentiation 25 and 95 and 154. This human blood assay is able to assess lymphocyte function and to monitor immunosuppressive therapy. The assay also may permit pharmacological analysis of the drug interactions, which will lead to improved safety and therapeutic efficacy. So according to this publication, using the flow cytometry to detect these various molecules are helpful in assessing the activity of immunosuppressions in general. As you can see, more than one drug has been tested. Another method of assessing the pharmacodynamics of immunosuppression was the quantitation of the antibody concentration, which, if high, means the patient is passing to rejection or there is insufficient amount of immunosuppression, and it's a very sensitive methodology. And despite the success, and I'm giving this example because this is what the authors used, and he mentioned that despite the success of using the IV IgG desensitization to reduce the anti-human leukocyte antigen antibody, its high failure rate and expense did limit its usefulness. And the quantitation of molecules of equivalent soluble fluorochrome allows early identification of these of the patients that are resistant to this type of therapy. So this is another pharmacodynamic related to assessing the effects of using intravenous immunoglobulins. In this research, they tested the levels of ATP. ATP is very important, and you notice that the cell is consuming energy and it's active. And the authors here found that the levels of ATP and immunosuppression, whether type dose or creatine level in white blood cells, was not affected at all, but patients with ATP levels in the low immune response before transplantation favored more infection. ATP, although it is helpful in this regard, yet when you look at ATP itself, it represents the overall energy metabolism of a cell and is not specific for immunosuppressive drugs, but there is a search for various methodologies in order to understand how drugs are active. Passing on to another point, which is the specific assay now. This is a specific assay for pharmacodynamic monitoring. And again, I'm giving an example of the CNIs. You can see that calcineurin is the key component of T-cell activation and serves as a target, as I have just mentioned, for the cyclosporin-related cyclophilin and the TAC-related FK506 over here. Inhibition of this signal of the calcineurin downregulation occurs, preventing the dephosphorylation of the nuclear factor of activated T cells. This would result in the prevention of the transcription and therefore the production of N-fat regulated genes that will translate into interleukin and IFN gamma and human necrosis factor alpha, all of which would help in proliferation of T cells. So directly assessing these cytokines is quite helpful, or assessing the cyclophilin levels itself is very helpful in monitoring CNIs. Here, a test was done to test the sensitivity of the whole blood T lymphocytes in individual patients receiving the CNI tacrolimus, and it was also addressing the impact of interleukin-2 messenger on the expression as a surrogate measure of immunosuppressive. If we are saying that cyclophilin, when it's inhibited, we will not have any more interleukin-2, which will bind to a specific receptor, CD25, then if we find levels that are low, the this means everything is okay, and if we find levels that are high, this means the patient is in rejection to soluble form of interleukin-2 receptors. Although this sounds very sound, yet it's not always like this. It is not that sensitive. We may have levels of interleukin-2 that are high while the drug is effective, and vice versa. The last methodology I'm addressing is the reversed transcriptase for polymerase chain reaction, and this provides a fast and highly reproducible and sensitive tool to quantify and analyze the gene expression. So by this methodology, we're able to accurately measure directly the functions of calcineurin inhibitors by assessing the genes by this technique. And inhibition of the activities of nuclear factor activated T cells means that these genes in the peripheral blood will be at a very low level. This assay is based on the quantitative analysis of also interleukin-2 and interferon gamma and the granulocyte macrophage originating factor gene. Now, just a few words about immunosuppressive drug interactions. I'm sure that all of you are well aware of these interactions, so I'm not going through the details. I thought this would be a very basic point to address. And I just have to enlighten you with a few slides. Cyclosporin, as opposed to tacrolimus, does inhibit the enterohepatic recirculation of LPA. So you have to take care when you lower dose and giving the patient LPA, you have to take care because you may have disturbances in the levels at this stage. And this could lead to early clinical LPA underexposure in 50% of patients once you decrease your C9 levels. You have to watch for that. Also, the combination of cyclosporin and PSIs, whether sirolimus or everolimus, requires dose adjustment and reductions of both drugs, because both drugs are definitely nephrotoxic. Before we thought that PSIs are not nephrotoxic, now we are sure and we know. And when corticosteroid doses also are substantially reduced during your follow-up of patients, you have to watch again for your other immunosuppression. They may need adjustment because of the progress levels would increase when you start to minimize or decrease the levels of steroids. Immunosuppressants are capable of interacting with various drugs, leading to either increased or decreased blood levels. And here are some of examples of these drugs. I'm not going to talk anymore about them, and rather conclude and say that the best way to individualize calcineurin inhibitor therapy is still a controversial issue. And despite strict efforts to improve graft outcomes by pharmacokinetic monitoring strategies, acute rejection and side effects cannot be ruled out. Pharmacodynamic assessment to determine biological drug efficacy in vivo is a promising tool supporting clinical decisions on the dose and type of immunosuppressive drugs. And pharmacodynamic monitoring is not supposed to replace pharmacokinetics by all means. They should be combined together to complement each other, as such, improving the therapeutic target dosage for more effective and safe results in our patients. Naturally, the future holds other considerations and other thoughts and ideas. Now we know the genome, and we realize that some of our patients are not responding favorably to the same drug at the same dose. Now there's a genetic background behind this. I'm sure Professor Hussein Shaisha, who's going to address pharmacogenomics, is going to enlighten us more. By these techniques, we will understand, and we come to understand, why is this happening? The same dose for two similar patients. One patient is rejecting, the other is not. He will tell you more about this particular point and about